think we're recording, right?
Yep.
Okay,
Just
great.
started.
All right, thank you guys for joining us for case reviews for November. Remember that we will not have case reviews in December. And without further ado, here's a couple of cases that we had in our county. As always, this information is confidential. We should not be sharing that within our outside of our organization, and we should not be copying it. It's protected with HIPAA. All right, so on to the first case. This is a case uh, that was recommended to me by one of the um, medics, Mr. Taylor. This was of a 31-year-old female that EMS got called for a fall. The patient was complaining of bilateral ankle pain. She was awake, her airway was open, and she was protecting it. She had a pulse in her upper extremities, but her lower extremities had no pulses. Her lower extremities were cyanotic. And the first set of vital signs were obtained 7 minutes after patient contact. Her heart rate was 58. Her blood pressure was 129/82. Her respiratory rate was 39, and her room air sat was 85%. I'm sorry, 95%, and her weight was reported to be 80 kilos. No past medical history was obtained or available from this patient, and no medications were reported. The mechanism of injury was that she had jumped off the 10th Street Bridge, which was presumed to be about a 40-foot fall. This was intentional, and she had reported that she landed on her feet. She did not strike her head to her knowledge, and she reports no loss of consciousness. She also reported no drugs or alcohol. She was immobilized prior to transporting agency's arrival, and this was at approximately 9 o'clock in the morning. As mentioned, the vital signs that were reported initially, they noted that she had bilateral open ankle fractures and that both of her lower extremities were cold, blue, and pulseless. They initiated transport 9 minutes into their encounter with her. At 12 minutes, they repeated her vital signs. Her heart rate was non-tachycardic, actually a little bradycardic, no blood pressure at this point. She was still tachypnic, and her SpO2 was reading at 68%. Her end tidal was documented at 13 millimeters of mercury, and that her blood glucose was 310. They established an IV, and they started to administer 100 mLs of IV fluids. They noted that they were having difficulty with getting an SpO2. They didn't believe that this was truly hypoxic. They thought that it was potentially just equipment malfunction. At 14 minutes, they had considered administering fentanyl, but had decided not to because they were worried that she was actually going into shock. They documented that they were having marked difficulty after the first blood pressure to even get a blood pressure subsequent. And at 15 minutes, they now have a heart rate of 144, still unable to obtain a blood pressure because it's not registering by cuff, and that her respiratory rate now is 32, and her SpO2 is still reading low at 53%. And again, they think that this is either due to equipment malfunction or possibly from shunting from shock. And her end tidal now is 14. At 16 minutes, they arrive to the hospital, and they note that she has, from the time that they first made contact with her, become more somnolent and more uncooperative as she's pushing them away whenever they're trying to do any type of treatment for her. The Pulsera notification was that this patient was a red. They had documented in the Pulsera that she had jumped off a bridge. They presumed at least a 40-foot fall, suicide attempt, history of previous attempts. They had documented and also discussed with me that she had previous lacerations to her upper extremities that were sutured, and that had been from an attempt a couple of weeks earlier. She had open bilateral fractures, which was a notification to the hospital, and that she was which were pulseless and blue. She was oriented, and as you can see, they have normal heart rate, a normal blood pressure, and a normal SpO2. So presumably that's the first set of vital signs, although it'd be definitely helpful, despite the fact that she's coming in as a full trauma, to notify if she's declining, so that they can be more prepared. So in reviewing this case, I thought that there was really quite a bit of work that was done conjunctly with both agencies, where they already had her spinal precautions, they had early vital signs, they tried to assess her vital signs multiple times after with, I think it was a 16-minute total time from patient contact to arrival to the hospital by the transporting agency. They documented her mechanism injury. They documented circulation, motor, and sensory exam. They activated appropriately as a full trauma, as a red, and we activated at the hospital as a full trauma. Scene time was less than 10 minutes. IV access was obtained, and that they considered managing her pain, but in lieu of her presumed shock, that they held off on treating her pain, which I think is very appropriate. Especially as we're trying to get her to definitive care. And then areas for improvement, if that, understanding that there a lot was going on with a short time with the patient, but 2 lines, potentially putting a blanket on her, turning the heat on, which these might have been done, just not documented. And, if she is truly hypotensive, we can put her in Trendelenburg, although, you're fighting the airway issues and if she's uncooperative. So consideration. And then, as mentioned here, an update to the patient's condition, especially if they're declining, which has actually kind of come up on another case. But, if your patient is worse, we want to know so that we can be better prepared. Sometimes it changes our receival of the patient. So like if your patient is a stroke alert and you end up intubating that patient, it'd be inappropriate for us to meet you at the stroke bay next to the CT scanner. We prefer to meet you at the patient's room so that we can stabilize them and then get them to CT, as opposed to not having any of our equipment ready for that unstable patient. So hospital follow-up in the emergency room, vital signs were a heart rate of 105, blood pressure 156/92, respiratory rate of 20, and SATs of 93% on room air. They got a chest x-ray and a pelvis x-ray, which I think will come up here. And I think, do I zoom in? Yes. So what you can see here is that, if you're crudely looking at this, you're looking for symmetry, that if you bisect this through the middle, you'd be looking to make sure that your iliac crests are symmetric. You'd be looking at the internal ring. You can see that it is not symmetric. If you look down here, you see that it is no longer in continuity with the left pubic symphysis. You see that there's a widening of this, as well as what looks like a little bit more inferior. And then it's subtle, but you can see, well, a radiologist can see an inferior pubic rami fracture. I could not. And then there's a sacral fracture, pretty comminuted up here on the left side. So based off of that, they put a pelvic binder on her because of her unstable open pelvic fracture, open book pelvic fracture. Her labs were significant for some acidosis with a pH of 7.17. Her lactate was pretty elevated at 14. Given the time since this mechanism, although suspected bleeding, her hemoglobin and hematocrit were normal. They hadn't had a chance to equilibrate. She developed hypotension in the emergency room and was started on the massive transfusion protocol. They decided to intubate her because of her critical injuries and need for resuscitation. They did document that they had to attempt 3 times to intubate her, but that was more related to the glide scope not functioning properly the first 2 times. So I will say that sometimes that happens to us in the hospital setting, but it seems like that's more of a problem with the pre-hospital setting, especially with the air tracks or something along those lines. I can't remember which one we had before him. Anyways, orthopedics met her at bedside based off of all of her fractures. So in total, this is all of her injuries found in the emergency room. So she had bilateral calcaneal fractures, which are heel fractures. She had a talus fracture and a navicular fracture, which are foot fractures on the left foot. On the right leg, she had a tib-fib fracture. She had a left tibial plateau fracture. She had a right tibial pylon fracture. She had a left radius and scaphoid fracture, so wrist. She also had intracranial bleeding, interventricular hemorrhage, although they said it was a very small amount. She had a thyroid laceration. She had a trace right-sided pneumothorax, and then she had lumbar fractures L1, L4, L5 of her transverse process. She had a highly comminuted sacral fracture, and she had moderate intra-abdominal and retroperitoneal hemorrhage, presumed to be mostly from her pelvic fracture. She also had a splenic laceration that was self-contained and a pancreatic contusion. She had bilateral right greater than left adrenal hemorrhages, and she had a grade 3 liver lac, as well as a left inferior pubic rami fracture, as mentioned when we looked at the pelvic x-ray. So lots of injuries from a high mechanism or fall from a height, great height. So last I looked, she's still admitted, but that was a couple days ago. So on hospital day 1, she went to the OR for external fixation of both of her legs and pins in both of her calcaneus or heel bones, as well as a pin in her talonavicular joint. She had a reduction of her left arm, and she developed a blood clot on hospital day 4, so started on heparin. Her past medical history was that she has bipolar disorder. She also has schizoaffective disorder, hypertension, hyperlipidemia, and although we thought she was in her 30s, she was actually in her 50s. Anybody have any questions or thoughts about this case so far? Cool. Well, like I said, this was suggested by one of our paramedics, and I thought it was a great case of discussion of a few things. One being falls from great height and our understanding of open book pelvic fractures. So this particular picture came from a search of fall from heights, and they were talking about for the BBC that there were over 200 cases of fall from heights unintentional due to selfies. This woman is standing on the top of someone else's shoulders above a 590-foot well. I don't know if this was her last photo, but anyways, fall from heights, these are considered greater than 20 feet or 30 feet, depending on where you're looking at. Most commonly, they're going to have spine injuries, 83%, according to a study that looked retrospectively over a couple of years. Let me see if I have the details of that. They looked at 101 cases over a couple of years that met the criteria of falls greater than 30 feet. So 83% will have thoracolumbar injuries. As expected, the higher you fall, the more likely that you'll have neurological compromise, such as quadriplegia or paraplegia. 45% of the time, you will find that they'll have lower extremity fractures, and most frequently, they'll be calcaneal fractures, up to 64%, and then ankle joint injuries. I mentioned this because when the medic had talked to me about this being bilateral open ankle fractures, and complaining of heel pain, I've had a case where a patient was not forthcoming about the mechanism and came in with bilateral heel pain. And so whenever you have either a complaint of bilateral heel pain and you see trauma, you should be highly suspicious that they may have fallen from a great height and that there's a high probability of a spinal injury, and a higher mechanism as well. So something to consider in general, because when he had started with the bilateral heel pain, I was like, how far did she fall? Um, and, some of these people will not be forthcoming about the history. Upper extremity fractures are also prevalent up to 25% of the time in these fall from heights, in that usually they're going to affect the distal radius from potentially falling with an outstretched arm or falling onto their elbow. There was no difference in injury patterns at 33 feet or greater than 33 feet, and that blunt abdominal injuries were uncommon. But in this particular patient, you may recall did have some blunt abdominal injuries in the form of her pancreatic contusion or splenic lac and her kidney laceration, as well as her adrenal hemorrhage. And then the other point, which I didn't make a slide for, is open book pelvic fractures. We are typically taught about these as being fractures that occur when there's like a force anterior to posterior. So usually the stereotypical mechanism is going to be a high speed MVC where the patient takes the knees to the dash and or the steering column to the pelvis or along if it ends up being displaced. And then, we talk about that we put on a pelvic binder whenever we suspect that it's an open book pelvic fracture. Usually falls from height, if they're going to cause a pelvic injury, it could be like a pubic rami fracture or a shear injury, in that a lot of times your pelvic binder could be detrimental. So we try to put it only on our open book pelvic fractures. And speaking with this medic, because he had wondered if he should have put a pelvic binder on her in the field, I think that, this is a great example, is that the mechanism that these types of injuries can occur not under the classic mechanism. And if you have a high suspicion for instability and your patient is shocky, it may be worth considering placing it, even if it's not our typical MVC injury. I don't know if any of our NPD's office have anything to add to that.
No, I think you just, if you push on this woman's pelvis, it's going to feel notably unstable. And that's the case where I would consider a pelvic binder. But I think that the key thing that the crew that, both crews did really well here is get off scene quickly.
Correct. Yeah, absolutely. Thank you. And then this is the heel bone. This is a calcaneus and repair, not hers, just a picture. So in reviewing our protocols that would be relevant to this would be, we don't have a per se fall protocol, but we have our trauma protocols. So this patient would meet our trauma criteria. And I would say that I would definitely call her a red, although I was kind of looking this over, and I would say vital signs would meet, but I don't see a height. I know that in the hospital we have a height contender. Am I missing that somewhere?
No, the heights in there are yellow. It says fall from height greater than 10 feet.
Yeah, I
Anything
didn't
that
see it
buys you.
over here.
So, but extreme falls like this, that'll buy, as far as that's paramedic judgment at that point, and as Dr. Mock said, if on a quick examination of the pelvis, this pelvis would have felt really unstable and she wouldn't have liked being examined.
They said that she didn't really complain about anything with her pelvis. They had so they said that she wasn't a good historian. So obviously look at the patient, but also can trust your exam.
Did they push on the pelvis?
That's what my understanding was, is that they didn't find an instability, and that it wasn't until they got to the hospital and they got a pelvis x-ray that they were wondering if they should have put in a pelvic binder.
Well, sometimes sometimes the magic doesn't work. You have to, it does take time when you're in a hurry and the patient's already essentially shocky. They're not going to be reacting normally. A lot of adrenaline going here.
Yeah, totally. And I mean, the distracting injury is the, obvious open fractures to her ankles. So I was just looking at here, if it was determined or suspected to be a pelvic fracture, it would make her a red. If there were two long bones, although she had a radius fracture, in a tib fib fracture, it wasn't necessarily suspected initially, because we probably were looking more at her legs, her behavior, and the mechanism. So I think that and like I said, they put it in as red trauma, which is appropriate and appropriate judgment, especially since there was a couple things that weren't suspected. But it's just another example of falls from height have a great chance of mechanism, and these are the worries that you have. And this patient had those and then some.
Right.
Yeah, great. Thank you, guys.
Yeah.
Moving on to the next case of a 6-month-old. EMS got called for unconscious, unresponsive. The child with CPR in progress. The child was unresponsive. The airway was obstructed due to saliva and emesis, and the child was also apneic. Noted to be cyanotic and pale, but warm. and dry with no pulses. I think the cyanosis was reported to be around the lips. At 1 minute after patient contact, they noted that the heart rate was not palpable, the respiratory effort was 0, and the GCS was 3. No past medical history, no meds, reported to be a full term without complication pregnancy. The history provided to EMS was that the child has been sick for a week with fever and congestion. They put them down for a nap after feeding. And when they went to check on the child was cyanotic, pulseless, and apneic. They last saw the child an hour earlier. So this was in late morning, 11:37. According to documentation, CCSO was starting CPR, and that they were the only bystander CPR. At 1 minute, as documented, the patient was pulseless, apneic, and a femoral blue IO was placed. At 5 minutes, the first epi was administered. End tidal was at 89, which would potentially suggest that there might be some hope. First rhythm was asystole, and at 6 minutes, the child was suctioned. At 7 minutes, an I-gel was placed, 1.5, and the patient was ventilated with a bag valve mask. At 9 minutes, a second round of epi was administered, end tidal now to 31. At 12 minutes, a blood glucose was checked, which was normal at 75. At 13 minutes, a third epi was given, 0.8, and the sats were documented to be 93%. They did write in the narrative that there was a lot of suctioning and a lot of secretions, which prompted them to decide to intubate the patient. At 16 minutes, they tried to intubate with a 3.5, but they said that the peds bougie was too large for the endotracheal tube, and the endotracheal tube packet was without a bougie. So they aborted that attempt, put the I-gel back in, I believe. And at 17 minutes, another round of epi was given. At 18 minutes, they tried again with a 3.5, and they were unsuccessful. They went back to resuscitating the child, and at 19 minutes, they upsized to a 4.0 ET tube and was successful in placement of a tube. At 20 minutes, there was a rhythm change, still pulseless, but PEA. At 21 minutes, another epi was administered. And then at 22 minutes, online medical control was consulted. They had told them to transport. And at 23 minutes, the child went from PEA back to asystole. At 25 minutes, another epi was given, and tidal still reasonable at 29. 31 minutes, another epi is given. At 34 minutes, another epi is given. At 39 minutes, another epi is given. At 41 minutes, another epi is given. And at 47 minutes, they arrived to the hospital, another epi is given. I believe in total, 11 epis were given. So in reviewing this case, this was actually recommended through the MPD's office as a case of a very difficult but well-managed pediatric arrest. Rapid assessment, PALS was provided quickly and appropriately to this child. Decision for intubation, given the continuous secretions and difficulty with suctioning, and then also knowing that in pediatrics, our more likely reason for cardiac arrest is respiratory. So getting that, getting the patient's airway secured as being the higher probability of the reason the child arrested. They went ahead and put in an IO femoral, and then they got a blood glucose. They contacted online medical control. The documentation was excellent, and the teamwork between the agencies was really succinct. Areas for improvement. So I would say under the procedures, this is not RSI. Your RSI is when you give sedation and paralytics. So this would be an intubation procedure, not an RSI procedure. And then just looking over your equipment before you're actually using it so that you can hopefully troubleshoot any problems before you're in the midst of doing the procedure. And that might have allowed us to recognize that the bougie wouldn't fit the ET tube. But obviously, these are high stress situations, and our fluid thinking is a little bit more jumpy. The only other thing that I can think about outside of this, and I didn't put it into the good or the areas for improvement, is the destination. So this patient was 3 miles from Legacy Salmon Creek, 9.5 miles from Peace Health, and 13.2 miles from Randall's. And the patient was transported to Randall's. How I think that this is, obviously up for discussion, but how I wonder or would suggest is that if your patient is still in cardiac arrest, that you'd go to your closest hospital to try to allow them to get ROSC and stabilize, and then they can transfer the patient to the most appropriate next hospital once the patient is stabilized, especially because there was such a disparity in the mileage. I don't know if anybody else on the call has any other opinions about that.
No, I would agree with that. And that would follow the protocol that even in a pediatric trauma, if they're in an arrest, you divert to the closest hospital. So, this closest hospital, you're talking resuscitation here, and you're not talking long-term hospital care.
Mm-hmm. Yeah, and I think that'd be something different if you had ROSC at this point, but
Exactly.
the child did not, and only briefly was there anything besides asystole for this unfortunate case. So the patient arrived at Randall's. They continued pediatric resuscitation. They did 3 additional epinephrines. They did get some imaging. They noted possible bilateral infiltrates, potentially pneumonia, potentially aspiration, and the child was pronounced shortly after. So in providing some additional information, I don't think there's a lot that I have for pediatric cardiac arrest in general, because this seems like something that we get a lot of education for just in regards to pediatric arrest. But I thought this might be a good opportunity to talk about. We're looking at potentially changing our pediatric tool to determine resuscitation and treatment and weights and heights. So we're looking at PediStat, which that's the app picture. This here is once you open the app that you can decide between weight, age, height, and Broslow if you're more comfortable with Broslow. Pulling up this kid for a 6-month-old. At the bottom, they tell you the weight, they tell you the height, and you can go under the cardiac resuscitation. Under cardiac resuscitation, it talks about general dosing and whatever rhythm the child is in. I pulled up for PEA asystole. So, the asystole and PEA definition is probably something that we don't necessarily need a definition for, but it can help us remind us on the interventions and the reversible causes. So it's a really great quick resource that we're looking into potentially acquiring for the county. And we can build it to be specific to our protocols. All right. So in review, our region protocols for cardiac arrest, asystole in pediatrics, you follow the adult algorithm. You're using the same concentration of epi, but a different dosing at 0.01 mg per kg, and repeating it every 3 to 5 minutes, not to exceed the adult dose if your pediatric patient is quite large. And then reversible causes, which are H's and T's. Anybody else have any thoughts?
Dr. Gadwell, could you go back to the actual case? I can't remember what the dosing was that they were using on this.
0.08 or 0.8, sorry.
0.8. Well, that seems a little high. If the dosing is 0.01 per.
Let me double check that. I'll have to look at, yeah, I agree. Like a 6-month-old shouldn't be almost the same as an adult. I may have omitted a 0.
Yeah, okay. That's what I'm assuming, but
yeah.
The other comment I would make on this is only, you know, we have to, and we have to do this for the for some of our medical control too. We can be lulled into a sense of like, oh, things are going better because we have a high CO2. That's not how this was set up or how this is supposed to be taught. Is the thing with CO2, if you have persistently less than 10, so 0 point, you have 9 or less consistently, you can consider that patient dead. And the other thing with CO2 and its value in CPR is not that you have a high CO2, which just really means that you're doing really good CPR, but and or you have them on a Lucas, which is really what we're seeing now, is that they always have they have a remarkable CO2 often, but that that in the case of an arrest, your CO2 starts out low and then it goes up. So it's a rising CO2 in response to your resuscitation treatment. So that is possibly predictive of a return of spontaneous circulation. It doesn't mean that you're going to get, if you have a consistent high CO2 or just even a normal value CO2, that doesn't mean that you're going to get ROSC. And that's a big that's something to get your mind about in this. Now that doesn't affect this case because I would have had this patient transported too because of the situations, and I just imagine that the scene was probably pretty chaotic with the parents, etc. And so sometimes this is necessary to transport, but looking at this there was really no after the first 25 minutes, there's no likelihood that this child is going to be resuscitated actually after the first 10 minutes, but we still do our best.
No, definitely. I just looked up, the documentation is 0.8 milligrams of 1 to 10,000.
That's a 0.8 milligrams. That's quite a healthy dose.
Mm-hmm.
So that's
Yeah.
about that's why your little reminders would be handy.
So here with this pedistat for this 6-month-old, it would be 0.07. So I don't know if there was a 10th off, but that's clear, like would be the dosing both in the milligrams as well as the milliliters for 1 to 10,000.
So I'm probably guessing in this case that was a documentation error because this particular crew was using hand Tevi.
Yeah.
Dr. Gebois.
Yeah.
So I'm looking at our hand Tevi app, which was what was used on this call, and Mark is correct. It's a documentation error. They gave 0.8 milliliters.
Yeah, I figured that it was probably the quantity of volume as opposed to the milligrams.
Yep. They put a milligram after it instead of a mill after it. Yeah. Well, see, we're all on the same page here.
Yeah. Awesome. Well, thank you guys. All right. Next case is of a 91. Oh, and actually beforehand, there was some conversation in the case in the chat. Station 43 said, what's the smallest ET tube that the PEDS bougie will fit? I thought it was 3.5, any use of iGel. And the response back was PEDS bougie goes down to 4.0 in the ET tube. And I hope that answers anybody else's questions if they're listening to this now or later. All right, next case is of a 91-year-old. EMS was called to a facility for a patient with a headache and neurological deficits that were reported to be new. The patient was awake. Her airway was open. She was protecting. Her skin was pink, warm, dry. There was no signs of bleeding. First set of vital signs were 4 minutes after patient contact with a heart rate of 97, blood pressure 153/66, respiratory rate at 18, SATs of 93%, and reported weight at 59 kilos. Her past medical history included anemia, COPD, GERD, hypertension, scoliosis, TIAs, and spinal stenosis. Her medications included albuterol, thinner in the form of clopidogrel, famotidine, gabapentin, loperamide, losartan, metoprolol, and pravastatin. So she also had hyperlipidemia and maybe neuropathy. The staff at the facility said that she had fallen 3 times in the last 24 hours, which was not typical for her. The first fall was 19 hours ago when she was getting her hair done at the hairdresser. And then she fell 4 hours ago out of bed, and they put her back into bed. And then she fell again later that early morning, which was what prompted them to call 911. The last time she was known normal was at 11 o'clock yesterday, and the call came in at 6:44 the following morning. The patient was found on the ground. They documented that they tried to stand the patient up to move to the gurney, but she was unable to stand. They got blood glucose at 20 minutes, which was 144. They placed an IV at 21 minutes, an 18 gauge, and they repeated her vital signs at 22 minutes, heart rate 99, more hypertensive at 188/87, respers of 18. Their physical exam was notable for a right-sided gaze preference, but no facial droop. Her speech was slurred. She had a left arm drift, a left hand grip weakness, and they initiated transport at 23 minutes. At 26 minutes, they activated it as a stroke alert. At 32 minutes, they repeated another set of vital signs, a little less hypertensive, but essentially the same, and they arrived to the hospital at 39 minutes. In Pulsera, they documented that the patient was found for approximately 30 minutes. Patient found on for approximately 30 minutes ago. So a little grammatically incorrect, but I assume that last found on the floor 30 minutes ago. Positive for stroke signs. Patient was seen at 4 a.m., had fallen out of bed. They picked her up, put her back in. Possible that stroke was not recognized at that time. They did not document last known well on this. They did document that she was on anticoagulation, and they also documented a race exam. For the right side and the left side. So in review of this case, the things that were done well was getting a blood glucose, assessing her neurological deficits, ensuring that a history of present illness as well as past medical history was obtained to let us know that she is on thinners. They got a last known normal, not in Pulsera, but not the most important thing in Pulsera, in my opinion. They got IV access and they brought her to a stroke center. Areas for improvement: if the patient's found on the floor, can't walk, maybe consideration of spinal precautions, especially since she's fallen so many times and on thinners, that, and definitely not a person that I would recommend walking. They documented the wrong neurological exam in their chart as well as in Pulsera. Their scene time for stroke KPI should be less than 20 minutes. So those major things. Those are the major things. In the emergency room, she was upgraded to a stroke neuro 911. Her NIHSS score was 15, so pretty high. Most patients, well, normal patients are 0. Most patients are less than 5, unless they have some pretty devastating neurological findings. And I believe the values can go up to 23. So pretty high. They determined that she was not a candidate for intervention, either for anticoagulation, and because of her last known normal. She also had an elevated troponin in the 1,000 range. They got a CAT scan of her head, no bleed, and they got a CT angiogram of her head and neck, and there was no large vessel occlusion, but there was left carotid stenosis at 70%. In the emergency or in the hospital, she had an MRI of her brain, which was essentially negative. Her troponins continued to rise, so she was determined to have a NSTEMI, which was medically managed only. They did an echo. They saw a new wall motion abnormality. Her ejection fraction was adequate, and she was discharged on hospital day 10 to a skilled nursing facility.
You know
Yep.
what her discharge neurologic assessment was?
They said unknown. They basically did not call her a stroke. I don't know if they called her an NSTEMI and falls, I think is what I saw as like the discharge diagnosis.
Okay.
So this is I thought a good opportunity to talk about stroke evaluations and what we expect in our county as well as what we expect in Pulsera. So why do we do stroke assessments? We do it to determine if how severe the patient, severity measurement to see how severe the patient is affected by what we suspect might be a stroke, predicting the diagnosis. So if we do these assessments and they don't have any abnormalities, we have less likelihood of them having a stroke, and that we want to communicate with the receiving hospital or to our other staff about what our assessment was and how severe it was. And it's also a guides treatment, and it allows for us to compare if the patient's getting worse or better when we have a value that can be, or a score that can be reproduced. And that we have multiple different pre-hospital stroke scales because of looking at sensitivity and specificity as in trying to determine if the patient does or does not have a stroke. So this gets us into a little bit statistics. If statistics isn't your thing, I would recommend taking a look at it on your own. But when we look at these tools, we're looking at how well do they perform in sensitivity and specificity. Sensitivity of a test is, you can think of it as, or an acronym that some people use as SPIN and SNOUT. So SNOUT being sensitivity, in that gives you a chance, higher the sensitivity, the more likely you can trust in ruling out the disease. And specificity allows you to rule in a disease. So a lot of times when we look at our stroke scales, we're looking at how sensitive they are to determining if there's a stroke, and that it's not always as specific because we want to gather or collect as many possible stroke cases and then determine if they are not a stroke after the fact. So that's why they're kind of, you might recognize that you call in a stroke alert and we don't upgrade them because our pre-hospital scales are trying to be very sensitive but not call everything a stroke. So hopefully that explains things a little bit. Cincinnati pre-hospital scale, that is when we look at the facial droop, the arm drift, and the abnormal speech. It's 94% sensitive and 20% specific. The Los Angeles pre-hospital stroke scale is pretty extensive. You can see that it's got 10 components, looking at left and right on some of those and calculating up to your values. So it's 91% sensitive and 97% specific, but it's pretty arduous. There's multiple aspects that you need to keep record for, and it's not easy to do without having some type of way to document on a paper to reference it. The RACE scale is a rapid arterial occlusion and evaluation scale. That also is another one that looks at palsy, motor, both arm and leg, gaze, aphasia, agnosia, and they score it from absent to mild to moderate up to 2 points. And depending on what your total score is, anything 5 or greater is considered concern for large vessel occlusion, but also some pretty cumbersome if you don't have it memorized. And I can tell you that we don't always have our LAM scores memorized. And then the RACE is 85% sensitive and 68% specific. And then the score that we use is BFAST, the balance, eye, face, arm, speech, and time. That is something that our acronym reminds us what we're evaluating. And when we do it and we do it accurately, it's 94% sensitive and 25% specific. So we want to identify patients that might be having a stroke. We want to not only identify them, we want to determine if there's a good chance that they might be having a large vessel occlusion that could require clot retrieval. How our hospital at Peace Health wants us to do this is not only just the BFAST, but the LAMs should be documented in Pulsera so that they can notify and make the neurointerventionalists aware that they might be called in to do a procedure. So we want our BFAST in there, and we also want a LAM score. And if that is something that you haven't calculated en route, we would want that in the handoff report if that hasn't already been done. What else was I going to say? So this case was brought up because they documented a race exam on the Pulsera as well as in their chart. I have spoken to a couple of our folks about this, and from my understanding, and correct me if I'm wrong in the chat or unmute yourself, that when it's not mandatory to put in a neuro exam when you open up a stroke call, I guess, in Pulsera, and that in order to put in the stroke assessment, you have to scroll up a long list of multiple different ones, and it doesn't scroll up or down. It's not the first one. So if that is accurate, that might be something that we can speak to Pulsera that might be able to change it specifically for us, that we can get rid of the other ones. But the only concern is that from speaking with those folks, they have an NIHSS in there. So that might be what they put in for the hospital. I don't know if we can just make it specific to pre-hospital and to our county only. But anyways, for our region, we want to assess a BFAST and a LAMS. We want to target their end tidal for 35. If we think that there's a bleed, we want to target their pulse ox to 94 to 98%. And we want to only activate patients that have had symptoms less than 24 hours, regardless if those symptoms are still present or not, and notify the appropriate facility. At Peace Health, we should be getting patients that have a LAM score of 4 or greater. And if we're not available for one reason or another, we recommend that we go to the closest appropriate facility, which would be Emmanuel, Providence, Portland, Sunnyside, Kaiser, or OHSU. Any patient that's over the age of 80 should come to Peace Health unless determined through online medical control. Symptoms that have been longer than 3 hours but less than 24 hours. Any patient that you think is a bleed, and any patient that is has profound paralysis, aphasia, or comatose. If the symptoms are less than 3 hours and none of the above criteria are met, they can go to the closest stroke center. And even TIAs are considered stroke alert if they're less than 24 hours, so they should come in as red. Anybody have any questions, concerns about that case?
Dr. Gamboa, it's my understanding, and I may be wrong about this, but it's my understanding that the thing with getting the race in there or getting a score other than what we have in the county is that as soon as a paramedic for the first time begins a stroke entry in Pulsera, the first time it comes up with that pick list, and then if you pick BFAST and LAMS, or pick BFAST, then from that point on, you're supposed to have BFAST pop up when you open that module. I think that's the workaround that at least Pulsera suggested to me that they put in, because they don't have any way of taking out.
So is that
that pick
only
list.
is that only for the case that they're currently on? They have to do that every case that
Nope.
they.
If
Okay.
my understanding is it's the first time they enter the Pulsera stroke alert thing. That from that point on, as long as they're using their own identifier, that will then be set for the correct thing. Now, a simple thing might be for the transport agencies to make sure that the paramedics open a stroke, a dummy stroke thing and get the right thing set up in their own thing. Now, we can check with Pulsera next week when we have our meeting with them, but that's my understanding of how it works.
Yeah, that'd be good. But the
Otherwise, we
two,
can ask them to.
I think you muted.
You just muted yourself.
Yeah.
Yep.
Huh. Interesting.
And Dr. Gadbois, could you go back to that previous slide, please?
Yeah.
So, and just a brief comment on, on why and the thought process behind this. So as you described, BFAST is a very sensitive scale, not very specific for stroke in general. And then, the reason that we use the LA motor scale is, number one, it's simple and straightforward. Number two, it only requires you to do one thing that's not included in the BFAST, which is the grip strength. So our goal is to, develop protocols that are simple, straightforward, and get the job done. And so that's the reasoning behind that.
Yep, absolutely. And then in the comments, oh, sorry.
Well, and the beauty of this is that if your BFAST is negative, you don't have to do a LAM score. But if the BFAST is positive, you have to do a LAM score, which is determining your destination then.
Yes. And I find that some crews have a LAM score when they give their handoff report and some don't. So something to remember to the expectation is that you would calculate your LAMs ideally en route and let us know through Pulsera, or at least by the time you arrive to the hospital and give your handoff report. And there was a question in the chat. So it says, just to be clear, any TIA-like complaint in the last 24 hours, even if no current deficit, should be a red stroke alert. And that answer is yes.
Correct.
All right. Next or last case too. 53-year-old male who EMS got called for a seizure. The patient was unresponsive. His airway was open, but he was not protecting it. He was known to be pink, warm, dry with no active bleeding at 8 minutes, which was documented that there was some aggressiveness from the patient, combativeness that might have contributed to the 8-minute time for vital signs. His heart rate was 140. They were unable to get a blood pressure. They did not document a respiratory rate, and they documented that his room air sat was 93%, and his weight was 99 kilos. He did have a past medical history of seizure disorder, as well as high blood pressure and anxiety. He took lamotrigine, lorazepam, trazodone, and amlodipine. His wife had reported that he had a seizure 2 hours earlier, and that because he had another seizure, she had called 911. And this current seizure has lasted approximately 5 minutes. They got called at 6:37 in the morning. At 5 minutes, they gave the patient 5 milligrams of IM Versed. Vital signs, as reported in the previous slide, the patient was reported to, or documented to be aggressive and combative. At 14 minutes, his heart rate was 121, blood pressure 152/101, respiratory rate at 20, and now his SATs are 91%. Due to concern for ongoing seizures, he got another 5 milligrams of IM Versed at 23 minutes, and he was placed on a non-rebreather mask. At 33 minutes, a peripheral IV was established in his leg. And I believe the reason why his lower extremity was used, not an IO, but a peripheral IV, was because they felt that he was too combative to be up towards his head and his arms. At 34 minutes, 5 milligrams of IV Versed was administered, and the decision was made to RSI him. At 40 minutes, he was given 150 milligrams of succinylcholine. At 42 minutes, he was given 30 milligrams of etomidate. At 44 minutes, he was intubated with a 9.0 tube with video laryngoscopy on first pass and ventilated with a bag valve mask. At 47 minutes, he was given 5 milligrams of IV Versed for post-intubation sedation, and at 48 minutes, he was given 100 micrograms of fentanyl. Transport was initiated at 50 minutes. At 58 minutes, he was redosed with 100 of fentanyl, and at 59 minutes, redosed at 5 of Versed, and he arrived to the hospital at 62 minutes. I couldn't find a Pulsera for this. I believe that they probably called this in. And in reviewing this case, I thought that they appropriately managed a seizure. They got IV access when it was safe to do so. They decided to move forward with protecting his airway. They used video laryngoscopy and his post-intubation sedation. Although, if you guys were looking at that, pain, fentanyl should come before Versed. Areas for improvement, no blood glucose was obtained. And the other thing was that he was given a paralytic before his sedative. So to perform that would be sedative, then paralytic. And then I thought that the size of the ET tube was large at 9.0, and then the lower extremity IV could be difficult. I think the reason why I put that in there is that there was question to if he if the Versed that they had given him for his seizure after his IV was established he was responding to it. And then they believe that there was concern that he also took a long time to get paralyzed and sedated, which was another issue or another concern about what was going on, and remembering that it's quite a bit from the rest of the body, the leg, and this patient had peripheral vascular disease, so it makes it even harder for it to circulate. So ideally, having access closer to the upper extremity or torso would be better. In the emergency room, he developed another seizure. He was loaded with Keppra. Neurology was consulted. They got a CT of his head to evaluate for any intracranial process, which was negative. During his hospitalization, they checked his Keppra level, which was subtherapeutic, and his lamotrigine was being taken adequately. He was restarted up on Keppra, and he was discharged on hospital day 3. So I have attended, I think a couple months ago, we had our airway lectures, and I realized that there was some teaching of putting in the largest ET tube that the patient can accept. And if I was in your guys's lecture, I had commented I didn't think the largest would be the goal, but the one that gets the job done as intubates the patient, but also ideally doesn't give you a cuff leak. So that doesn't necessarily mean that it's the biggest thing that you can find. So, and it made me kind of aware of, I'm seeing more cases of 8.5 and 9.0 tubes. So I did a little bit of research to hopefully give us a little data to decide the most appropriate. And I believe that our office will have a recommendation here shortly as well. So this study looked at endotracheal tube size in critically ill patients. They wanted to know if smaller ET tubes were non-inferior to larger ET tubes. Looking over my notes real quick. So this was a retrospective cohort study that looked at a 6-month period. I think June 2020 through November 2020. They looked at 814 patients that were intubated in the emergency room or the ICU. So these were no pre-hospital patients, and they had to be intubated and on the ventilator for at least 12 hours. They looked at the all-cause in-hospital survival at 30 days, and they saw there was no difference in smaller for size ET tubes and large and regular sized or larger for ET tubes. They did say that the smaller ET tubes were not associated with impaired recovery. Actually, so the one thing they mentioned is the smaller ET tubes meant that they seemed to see data that showed that they may have been intubated for a longer period of time, But overall, from this data of their 814 patients, they determined that a smaller ET tube was not associated with impaired recovery, and that because we know large ET tubes can have all kinds of potential complications, that it was better for laryngeal anatomy to not use a large tube. See if there was anything else. I looked at another study, which I didn't put in here just as an interest of time, looking at if intubated with inappropriate size ET tubes can cause long-term tracheal and laryngeal injury. Showed similar information that the old teaching is the largest tube that the patient can accept is not, we're seeing that in practice, that is not how our colleagues are practicing, and that has to do with not being able to place the ET tube, causing oral trauma or vocal cord trauma or laryngeal trauma, and pressure injuries from the balloon and the tube. So in reviewing of sizing of an endotracheal tube, there is some recommendations based off of gender and height. In the there's some information regarding height that the taller the patient, the larger the tube potentially. If the tube is too little, it can lead to a cuff leak, and it can make it difficult for bronchoscopy to be performed. I believe the smallest tube that a patient can be bronch through is a 7.0. I don't know if Dr. Mock knows that differently. But
yeah, it becomes a little bit like they're limited in what bronchoscope they can use when it gets below 7.5 or below. But they're now smaller bronchoscopes. And so, and it's also easy to size the tube up. So I wouldn't place a larger tube for consideration of potential future bronchoscopy.
yeah, and I mean 7.0 or 7.5 is like depending on the cutoff. So I mean that would be appropriate. Too large of a tube can lead to sore throat, hoarseness, vocal cord injuries, tracheal or glottic injuries, or you're unable to place the tube in the first place. There was a case in our county not too long ago where they tried to place, I think it was an 8.5 ET tube. They thought that it was through the vocal cords. When the patient arrived to the hospital, the tube was too short or too shallow, and they tried to advance it, but they couldn't advance it. And it was because the tube was too big to pass through the vocal cords. So the tube was just sitting on top of the cords. So again, we really, in this situation, we are trying to secure an airway, not just have another device just above the cords like a iGel. And then, in speaking with some experts in the field in regards to airway anatomy management and ventilatory support, there was some conversations about tubing compliance for ventilation with a smaller tube, but they found that is, with the mechanics through the ventilator, that is less of an issue than it used to be. So I believe, at least where I stand, and I haven't vetted this with my colleagues here, but that male adults should be getting intubated with a 7.5 or 8.0 as a rule of thumb, and adult females should be getting a 7.0 to 7.5 as a rule of thumb. I don't know if that
I agree
is shared with my
completely.
colleagues.
Yep.
I agree completely, and there's no reason to place anything larger than that, and there's potential harm.
Yeah.
Agree.
And I discussed that also with the pulmonary critical care docs, and they're completely in agreement. They would, they've almost never used a tube larger than that, and there's definitely not an indication to place that in the pre-hospital environment. If cuff leak is the concern, you can inflate the cuff more.
Mm-hmm. Or they can exchange it out, but we want to place the tube, not miss our chance because we tried too big of a tube.
Correct.
Cool. And then, I looked through our protocols. We don't have any guidelines we have guidelines for pediatric tubes, but we don't really have any guidelines for adult ET tube sizes. So I just put up the advanced airway procedure, which we're all familiar with. I looked at a couple other agencies across the county, and they also don't have guidelines for adult sizes. So that we're not the only county that doesn't, but just as a thought. So that is, unless anybody has any questions or comments or thoughts on the last case with a 90 ET tube. So in review, patients that fall from great heights have multiple potential for injury. So our suspicion of index should be high. Even if your patient seems to only be complaining of one or two things or no things, I would at minimum immobilize them and have access on them and serial vital signs and a good exam on them. As for stroke patients, the only stroke evaluations that we support would be BFAST and LAMS, and both of those should be performed and entered into Pulsera at worst case scenario presented as a handoff report. And there are multiple sizes for ET tubes, and that going big isn't recommended, as in we should be looking at 7.5 to 8.0 for adult males and 7 to 7.5 for adult females. And that's all I have. Anything else from EMS or the MPD's office?
Yeah, very nice.
No, great. Thank you.
Thank you.
If there's anything else in the chat. Oops.
I didn't see anything. Just thank you.
Yep. All right.
All right. Thanks.
Thank you.